Next speaker is Dr. B. Poornachandra. He will be speaking on variation in genes, genetics, and possible repair, Indian community perspective.
Dr. Suprita is there. Right.
So good morning, everyone. So as we all know, in the last 15 years, there are more than 500 disease-causing genes have been identified in the eye, and most of them is related to the inherited retinal dystrophies. This is the typical conversation which happens once we diagnose retinal dystrophies. You have retinal dystrophy. How do we cure this? Sorry, no cure. Can you do something to treat? Nothing to treat. You can use low vision aids or go for rehabilitation. Then patient will ask, will this condition pass on to next generation? You can go for genetic testing. Then patient comes up with a series of questions like, does my vision going to deteriorate? Will I go blind? Can I do something to stop the deterioration? Is there a possible therapy in the future? To answer some of these questions, these needs to be studied comprehensively in the Indian context. So with this, we began a study where we identified the families with inherited retinal disease, identified and isolated the mutations, studied these mutations in cell lines, and how to repair this mutation, and also we studied the effect of the repair. This was an observational study approved by Institutional Review Board. All patients underwent comprehensive evaluation, including imaging, and electrophysiological tests were done wherever it was required. For genetic testing, we used next-generation targeted sequencing using 240 retina-specific genes to look for the variations. Among 5,108 IRD patients, 524 patients opted for genetic testing. Among this, the predominant mutation what we found was ABCA4. However, the other mutations which are reported in the literature are also present. So coming back to my title, how this data helps us to understand variations, genetics, and possible repair. Let me explain you the case example. This was a 43-year-old female who had a macular atrophy. When he did a genetic testing, we ended up discovering totally new gene which was not reported. Incidentally, the symptomatic father and asymptomatic children were also carrying the same gene. When we screened the father, he did had a macular atrophy. The children were asymptomatic with 6/6 vision, near normal fundus, OCT was also normal. But if you look at the macular autofluorescence, there is an abnormality. So this is the OCT and autofluorescence across 3 generations with increasing severity. If you want to stop this progression, the only way is therapy. I'll come to it later. So this is one more interesting family where the 14-year-old female presented with foveal atrophy. When he did a genetic testing, she had a compound heterozygous mutation in ABCA4. Mother was asymptomatic with 6/6 vision, was homozygous for one of these mutation. However, when he did an autofluorescence, there were subtle changes in the perifoveal region. So this is a typical example for same disease, same gene, same family, but the severity could be different depending on the mutation what they have, which is very common in Indian context. So study the effect of these in cell lines, we used human embryonic kidney cell line. To make this simple to understand, the darker the band, the better the protein function. I'll explain it the case example again. This was a 13-year-old male with a V type of mutation who had a very mild disease. As compared to the second one, 9-year-old male who is 4 years younger to the first patient, had a Q type of mutation with a very poor protein function, he had a very severe early onset macular atrophy. And ERG was also telling the same story. In first patient, it was almost near normal. In the second patient, there was a severe rod cone system dysfunction. So how to repair this? So let's see what gene therapy can offer in this group of patient. So there are some challenges when it comes to producing clinical grade vectors in India. That's the reason the already approved gene therapy product, they costing crores, which most of the Indian patients cannot afford. 99.99% cannot afford. So these vectors needs to be produced in-house, which is a little complex process which involves transfection, harvesting, and it has to undergo multiple purification process. Even then the challenge remains. Some of the commonest gene what we find in Indian community like ABCA are very large genes which cannot be loaded into the single variants. That's why we came up with a novel dual vector strategy where we split the gene into 2 loaded into the separate variants. Once they are co-infected together, they reach the target cell where they are expected to function normally. So these were all produced in our own vector production facility, which is the first in India. And we used Stargardt disease mouse model. This is the mouse autofluorescence. As compared to the normal mouse, the mouse with the ABCA4 knockout has increased autofluorescence. Once we injected our dual vector, as compared to the treatment naive and also the mouse which received the control vector, the mouse which received our dual vector, there is a significant decrease in the autofluorescence. We went one step ahead and did ERG in these mice. As compared to the controls and the non-injected mouse, there is an improvement in both outer and inner retinal functions. So to conclude, I would like to say what was known was this is where we used to end. This is a dystrophy, nothing can be done. What this study adds is genetic sequencing and screening from Indian families, new genetic and phenotypic variations, and pathogenicity of mutations were studied, and animal models to study the effect of dual vectors were also studied. The next step is to start the human gene therapy. I have showed an example of ABCA4 gene. Since the sequencing and the vector production is done in our own facility, it can be done for any other genes. Thank you so much.
Have you actually done it in a few human eyes?
No, sir, this is just the animal
Right,
trial we have.
model.
That's why my future plan, based on this data, we'll be starting the human trials.
Right. And you've seen success in those
Yes.
animal eyes?
Yes, sir, definitely. As I showed,
Yeah.
the autofluorescence definitely decreased because we know that the ABCA4 results in excess lipofuscin accumulation.
Right.
Once we inject a dual vector, this disappeared. That means our gene is producing the protein which is able to digest this autofluorescence. And also we did ERG in this mouse because these were live mouse, where there is an improvement in both A wave and B wave amplitude as compared to control. Stating it's not only the structural improvement, there is also a functional improvement in this one, which is surprising. It is an added benefit.
How many cases?
The mice, sir?
Yeah.
No, we have used 60 mice, sir, in this one as a control and this thing as where they were injected. As a control, there were 100 standard mouse which are there. And we have a different mice for cell line. This, what I showed was a ABCA for knockout mice. Like that, we have a different model for RP65 and things like that.
And in almost all cases, you see an improvement?
Yes, sir. Yes, sir. It was an uniform response which was seen. There are few mice which developed like cataract, endophthalmitis and all. Those were excluded from the study.
Thank you so much.
How many days the follow-up?
Sir? So these mice we have still the 6 months follow-up. The ERG was done at 3 months. We have total of 6 months follow-up, and this mice which are able to survive, we are planning to repeat the ERG again.
Only one injection was given.
Only one injection given. That's our aim in human trials also.
Thank you.